All right, I'm trying to do some more recordings for you guys, especially for the final. So we'll cover, excuse me, inflammation, immunity, and hypersensitivity. So, all right. So I've already gone over this with some of you in office hours, and it's been posted. But so you have this document already. But these are the concepts that we're discussing, interrelated concepts. When we look at immunity, inflammation, infection, that gas exchange, pain, and perfusion. That's what this is over. All right. So it's always finicky when I'm trying to figure out how to turn things. So these are the exemplars. There's a lot of them. Transplantation, right? Both liver and kidney, and then organ rejection failure. Anaphylactic reaction as well as distributive shock, but I went more into distributive shock with sepsis. So I'll probably breeze through that here. Some ICU delirium, which I think I need to add. I can't remember if it's in here or not. Probably need to add it to my final presentation. Infection, as well as anaphylaxis as it relates to also with transfusion reactions. Okay. All those exemplars. So what's distributive shock? If you watch the sepsis, I think it's more sepsis video, I have it in there. Here's just another idea of it. And we picked distributive shock to go with this because that's really the only type of shock with anaphylaxis. Distributive shock has a whole table of different types of manifestations that are associated with it, right? Environments like sepsis. So as a reminder, blood volume is not lost from the body, but it's distributed to those interstitial tissues. So in that space we can't measure, you know, in those capillary beds, and it really impacts mean arterial pressure. It's inversely related. So anaphylaxis is a type 1 hypersensitivity response. This is really a review of patho. We talked about type 1, type 2, type 3, and type 4 in patho. I talked about it. I know you guys had it as well. So you can always go back to that book as well. Plus it's in this book explained really well. But really type 1 hypersensitivity reactions, they're typically a life-threatening reaction, and failure to rescue is the reason that patients die or people die if they're out in town as well, right? If they're allergic to bee stings and they don't carry their EpiPen and their family doesn't know about it. So it involves all the blood vessels, and it's a vasodilator. Bronchioles, it's a smooth muscle vasodilator is what happens in that anaphylactic reaction with the sympathetic nervous system. Widespread blood vessel dilation, so pooling of blood. The cardiac outputs decrease, but they have bronchoconstriction. So smooth muscle dilation, and bronchoconstriction. It's the most life-threatening reaction, as we know. So criteria 1, 2, and 3, and really, like I think I told you guys, if you're in office hours with me, these are really hard to differentiate. So on the final, you know, no new information is going to be given to you, but remember, so you can review these criteria within minutes to hours. This is what happens to the body. I think of this with a bee sting, peanut allergy. What's another thing you could say? Those are the two big ones that I always think of: peanut allergies, nut allergies, that is, bee stings, and I mean, it could be to animals as well, right? But a criteria 2, minute to hours also, with 1 or 2 or more of these symptoms after exposure to that allergen. So here it's respiratory distress, which is all bad, hypoxia, cyanosis, dyspnea. Hypotension and indication of reduced perfusion. So this is a criteria 2 is onset within minutes to hours with 2 or more of these symptoms. So mucous membrane problems, swollen lips. You can think of some of the beta blockers that cause this, or some of the calcium channel blockers. Respiratory distress. So some wheezes, hypoxia, cyanosis, and those bronchospasms as well. And hypotension, evidenced by decreased perfusion, decreased cardiac output, or pooling of the blood, and then some GI problems. And then it's criteria 3. So I've yet to see it really differentiated anywhere, like in a chart in the ICUs, anywhere else, or in the ER. Emergency care, as we all know, ABCs, call an RRT, get ready to intubate or tracheotomy, be due to inflammation, especially if they have a bronchospasm that can't be broken with nebulizers. High flow oxygen, you might have to assist with breathing, bag valve mask. If they're receiving anything intravenously that caused it on the floor, let's say they had a second dose of Ancept, or Recefin, that is, or they're getting a blood transfusion or an iron infusion, that is, stop the fusion and disconnect it. Start some normal saline, right? Do not discontinue the IV though, right? Because what is going to happen to them? They are going to vasodilate. You are not going to be able to get a new IV, okay? If you have to start another IV, start one if you can, but never discontinue that IV, right? Prepare for epi. You can give it every 5 to 10 minutes intramuscularly. You start it, give it. The head of the bed, about 10 degrees, just to keep perfusion to the brain, but raise those feet and legs to help with that pulling and that smooth muscle dilation and get blood returned back to the vital organs, and then stay with them, obviously. So it's more common. So with acute transfusion reactions, if blood is older than 30 days old, they're likely to have a transfusion reaction. It could be related. Bacterial is a different type of transfusion reaction. So multiple transfusions that have been administered, why do you think? Well, due to the fact that they're going to have antibodies or built up to different blood, even though it's cross and type match, it's coming from a different person. So they're going to still have those leukocytes in there unless it's leukocyte reduced blood. So the more transfusions they receive, let's say it's a sickle cell patient or an oncology patient or a patient with anemia, the greater the likelihood that eventually they're going to have a transfusion reaction. So follow the nursing protocol at the hospital, right? It's stop the blood, all right? Discontinue it. Do not flush that line. Hang a new bag of saline. If you anticipate it in a patient, say they tell you they've had transfusion reactions in the past, hang a second line of saline. So, and you have to educate the patient on signs and symptoms. And these are them right here. So you'd say, hey, if you have any low back pain, you feel like you have a fever or rigorine. Most of the times transfusion reactions occur in the first 15 minutes, acute transfusion reactions like that, but they can be delayed. So you're going to be with that patient for the first 10 to 15 minutes anyway, typically taking vital signs every 5 minutes, depending on the nursing protocol. So if the patient is febrile, they'll spike immediately. It's common after white blood cell platelet or multiple transfusions, like I just said, because they have those anti-white blood cell antibodies. They end up trying to fight it off. They can have chills, tachycardia, hypotension, tachypnea. They can, leukocyte reduced blood or single donor HLA matched WBC filters will be helpful in this scenario. So hemolytic, that's a blood type incompatibility. So you've hung the blood on the wrong patient. Someone drew blood and labeled it wrong. It happens. That's why you require 2 registered nurses and 2 identifiers. That's why patients identify their own blood. They should be when you're drawing blood like this. Okay, you verify what was drawn, you watch them label it. So, there are different antigens. It destroys the transfused cells and starts that inflammatory response. It can be mild or moderate, or it can end up with life-threatening with DIC, disseminated intravascular coagulation. So this can be immediate, or it can happen after subsequent units have been transfused. But hemolytic, when it's a blood type or RH incompatibility, typically is going to be something that happens immediately. Let's see. Blood transfusions are never anything that should be delegated, all right? You don't say, hey, my patient needs blood. Will you give it to him? I'm going to lunch. Because you know your patient, all right? You know who that person is. You're better off, getting that transfusion started, wait with them for those first 15 minutes, and then let your CNA or somebody else sit in there with the patient if need be, if they're at risk, or family, So allergic reactions, anaphylactic, patients with other allergies. That's another type of transfusion reaction, okay? It can happen later on. So you can administer leukocyte reduced or washed red blood cells in the future, or if you anticipate this to happen, or if they've had an allergic reaction similar to this in the past, okay? Bacterial is when the blood's been contaminated for whatever reason, okay? It was presented contaminated, whoever donated it had an infection, right? Or it's old. These are, they're going to look like signs and symptoms of sepsis or SIRS. It's a rapid reaction. Acute lung injury, circulatory overload, and graft versus host disease. Trolley, it's a lung injury, acute lung injury, transfusion-related acute lung injury. So they happen to have antibodies against the donor blood contains antibodies against the recipient's neutrogens. Okay. It's a rapid onset. They have shortness of breath. They often require intubation and mechanical ventilation because there is trauma and damage to the lung tissues. With TACO, transfusion associated circulatory overload, you've infused that blood too fast. Older adults often can't handle the volume overload. It's going to impact their cardiac function. The heart muscle is too weak. Whole blood is much larger, or volume of blood that's given by, if you're just giving red blood cells. And it's difficult to differentiate the two. These patients often might just need diuretics, slow the rate, monitor the eyes and nose. Typically, we start it slow anyway, right? And then we speed it up. Blood has to be transfused from the point of pickup to in the patient's body within 4 hours, or they're at risk for bacterial growth, right? That being said, if you're in a trauma situation, you will just pump it in. So graft versus host, it's rare. These people are often immunosuppressed. It's more like a stem cell transplant occurs with. So, you know, these are things I've been sort of talking about all along. Stop the transfusion, remove the blood product and the transfusion, but you got to save it. Initiate normal saline. Do not DC that IV. Follow the orders. There are transfusion reaction orders associated with blood transfusions. You have to monitor their vital signs and urine output. You're looking for any blood in the urine. Okay, looking for any kidney damage that might have occurred. Let's see, always re-identify everything too. After you've gotten the patient stabilized, depending on what you have to, you know, you might have to give them epinephrine, you might have to give them oxygen, you might have to give them some Benadryl, you might have to give them an H2 blocker. It just depends on how severe the reaction is. But if the patient starts rigering, starts complaining of lower back pain, you need to stop the transfusion. So, and there's a transfusion reaction report. Everything gets sent back to the lab, and pathology will look at it. You always document signs and symptoms and reassess the patient and their family. Okay, it doesn't mean they can't get blood ever again. Sometimes patients have to be pre-medicated prior to receiving blood. You'll give them Benadryl and Tylenol because they're at higher risk for having those mild reactions. All right, now we'll skip to transplantation. So with liver, for patients with end-stage liver disease or an acute liver failure, they're candidates. So transplantation should be considered. There's complications, and then the interventions after transplant, worrying about psychosocial impact, the side effects of those immunosuppressant drugs, and then that lifelong management of those immunosuppressant medications. With COVID, they've seen an increased rise in liver transplants or liver transplant wait lists due to the increased amount of alcohol consumption. So what these patients are contraindicated. You know, anyone who has metastatic cancer, they can't follow instructions for drug therapy. Unfortunately, if they're homeless and they don't have reliable, you know, that's what I would think of with that. Not that they don't understand, they're unable, but they just don't have the resources. So if they have cardiovascular instability or advanced disease of some other form, you know, unfortunately, they're not candidates. And then any severe respiratory disease. The donors, there's different types. There's trauma victims, right? They have no liver damage. It's transported, preserved. It lasts about 8 hours. The diseased liver is always removed from the recipient, and the new liver is put into place and attached to the blood vessels and those bile ducts. So patients with the highest acuity level receive this. There's no type and cross. There's no match. Living donors is usually somebody close to you. They have to be at least 18 years old. It's a voluntary basis. The donor's liver is resected to one lobe. One lobe is resected and it's implanted into the recipients after removing the diseased liver. Both livers regenerate and grow based off what your body needs for both the donor and the recipient. These complications are acute graft rejection. So it's treated very aggressively. It happens quickly after transplantation. You know, they're taking immunosuppressant drugs, so that puts them at greater risk. They're at risk for multi-system organ failure, and coagulopathies like DIC, and that portal systemic encephalopathy, which is confusion as well in the brain, right? A buildup of pneumonia. So acute graft rejection has to be treated aggressively with antibiotics, increased immunosuppressants. Infection, you know, vaccinations and prophylactic antibiotics do help. Okay, immunosuppressant drugs that they're on also put them at greater risk for infection. All those tubes and intravascular lines increases it so that sooner they can get them out. The Foley catheter, the central lines, if they happen to be intubated, the sooner you can get out any invasive lines, the decreases the risk for infection. Obviously, they're at risk for bleeding. Hepatic complications, they can have a biliary leak. They can have an abscess form, right? And hepatic thrombus, a clot that occurs just from the increased coagulopathy. I mean, yeah. So, and then acute kidney injury can happen from hypotension, antibiotics, cyclosporines that are on acute liver failure and hypothermia. So where the body is put into a colder state, puts them, the longer you're placed in that colder state, or the liver is placed in that cold state, it decreases the oxygenation to that kidney. So increases the risk for injury. So kidney transplant, the patients, they have to have a match, right? Advanced kidney disease, reasonable life expectancy, they have to be fit for surgery. And in the US, their glomerular filtration rate must be less than 20 milliliters a minute. Okay. Obviously, if they have metastatic cancer, they have an ongoing infection, they have some psychiatric illnesses. I think that's where I was thinking of. Sometimes a lot of homeless do. They don't all, but many homeless have psychiatric illnesses. They're not going to be compliant with medication. If they're still using drugs, alcohol, same thing with a liver transplant, they can no longer drink. And if they haven't been compliant with their dialysis or the medical regimen, they're not going to be a transplant for kidneys, a kidney transplant. There's living non-heart beating in the cadaver. Obviously, the living donors, they have the highest rate of survival. Okay. They have shorter, colder ischemic times, right? So that ischemic reperfusion injury is less. Obviously, the living donors must be over 18. So if you have a sibling that's a match, they can give up one of their kidneys. So long as they're both healthy kidneys, your body's going to compensate, and you can live with one kidney. So with non-heart beating donors, let's say somebody who just went through CPR therapy, they're going to harvest it immediately. A lot of times these patients will be put on life support until they can take all the body organs, right? But they're still dead, okay? But something is pumping for them. Let's see. It's preserved by cooling, a preservative solution. And then cadaver donors, they can take a kidney from a cadaver donor and try for a transplant, but they have a higher graft versus host. They have a higher failure rate of acceptance. So preoperatively, you can see what they need done, right? They have to be typed and crossed, okay? And human leukocyte antigens, I think, HLA, and blood typing. The more similar the antigens, the more likely of the success. So they want to look at the HLA. Let's see, they are going to have dialysis 24 hours before surgery, and they'll get a blood transfusion, ideally from the donor, because then you're getting those antibodies in there, and the body's going to recognize it a little bit better. Have less likelihood of having a rejection. So failed kidneys are left in place. Don't ask me why. I don't really know why. As long as they're not infected, I can't, I haven't really found it other than it's a cavity in a space that needs to be filled. The new kidney is placed in the right or left anterior iliac fossa. It's easier for palpitation to see if they start to enlarge. It's easier for reanastomosis to the arteries and veins and nerves, okay? There's placement right here. It's lower, whereas your other kidneys are way up here. Postoperative care, pretty obvious. Why are you looking at these things? Monitor for daily weights. You want to make sure they're not retaining fluids, that they're making urine. Hourly urine for the first 48 hours, they might be prescribed continuous bladder irrigation, especially if they are throwing some clots. They are at risk for CODI because they're also going to be immunosuppressed. You want to monitor for fluid overload, and obviously you're going to monitor their blood pressure for that. You want to look at, make sure their renin and their RAS system's functioning as well. All this stuff can help look at cardiac output and look at perfusion. We already know this. Reduces immunity, impairs healing, and increases the risk for infection, but they require it because otherwise they're at increased risk for rejecting that donor, the donor kidney. Oliguria, ischemia or acute kidney injury can cause it, a rejection or other complication. Sometimes they will give them diuretics or osmotic agents to try and improve urine output. Osmotic agents like albumin to pull volume and fluid in. And diuresis. If they receive a live donor's kidney, they often will have massive, rapid diuresis because of the perfusion is greater. So you need to monitor for what? Potassium levels and sodium levels. And monitor for hypotension if they're going to lose that much volume that quickly. Complications is rejection, obviously. Hyperacute, acute, chronic, and stenosis. So hyperacutes within 48 hours. They might have to remove the kidney because I put it in blue. They're elevated temperature and blood pressure, and they're having a lot of pain. They'll initially try to increase immunosuppressant therapy. Acute reaction, well, it's just actually acute reaction. A week to any time afterwards. So oliguria or anuria, little to no urine output. They're lethargic, lethargy, meaning they're exhausted, they're tired, they have no motivation. Their kidneys enlarge. They can palpate the kidney in that iliac crescent area. They might have a low-grade temperature, over 100. Their blood pressure might be up. They're hyperdynamic. Their BUN and creatinine are up, along with potassium. They'll have some fluid retention. So they'll increase the immunosuppressant therapy. With chronic, they're going to have a slow, gradual increase of their BUN and creatinine. Chronic transplant complications. They'll have fluid retention, fatigue. Their serum electrolytes will be affected. And then they'll treat them with conservative management, maybe diuretics, ideally, or, low sodium diets and dialysis periodically or routinely. And that's not the goal of it, but maybe they'll end up with less dialysis than they were before. And then a stenosis that can result in hypertension. You can hear a bruit over the anastomosis site. They have decreased kidney function, and they can do a CT scan or a regular scan, or like an ultrasound or anything else to evaluate perfusion. They can look at artery and venous blood flow. And they can treat it just like they do with a cardiac stenosis, treat it with balloon angioplasty. Infection, hematomas, abscess, and lymphoceles. The way to prevent these things is by strict aseptic technique and hand washing for these patients. Immunosuppressant therapy for kidney transplants, the likelihood you're going to have the same things for liver transplants. Corticosteroids, inhibitors of T cell proliferation, that's azathioprine and cyclosporin. MTOR inhibitors, monoclonal antibodies, they always start with high dose during induction, followed by lower dose and a maintenance therapy for the rest of their life. The goal is to maintain appropriate fluid and electrolyte balance with these guys with a kidney transplantation, maintain adequate nutrition status, avoid infections, and, effective coping techniques. Most of these patients are going to have a much better outlook on life if they're not going for dialysis 3 times a week, right? And similar, I think that's the same thing. I think it's just repeated. So I will let you go through these. The correct answer is at the bottom of the slide. Okay. And hope you guys enjoy that. I have to figure out how to pause it. Alt-C. Stop it. I thought I stopped it, but I don't think I did.